Good afternoon. Thanks everyone for joining us. Welcome to our August monthly webinar. I appreciate everyone taking some time to join us, especially on the week leading into a holiday. So we'll try to make this quick and hopefully very informative. So today's webinar is called the ADT It Factor. And before we get into that, we always like to start our webinars with just a little introduction to CalHIPSO. We do get quite a few people on these webinars who are not familiar with CalHIPSO. So just in case, CalHIPSO is a 501c3 nonprofit founded in 2010 by the California Primary Care Association, the California Medical Association, the California Association of Public Hospitals and Health Systems. We were originally created to be the regional extension center for the vast majority of California, and our mission is to help providers navigate the complicated world of electronic health record adoption and health information exchange use. As I mentioned, we were originally formed to be the rec for California. Recently, CalHIPSO has started to branch out into many more areas. Our current or upcoming projects include Medicaid meaningful use under the California Technical Assistance Program, encounter data submission, and practice transformation support services for accountable care organizations. Across all our programs since our inception, CalHIPSO has provided technical assistance to over 13,000 unique clinicians up and down California, spanning more than 1,400 organizations statewide, and we've helped providers earn more than $300 million in federal incentives. Today, we are very happy to be joined by our friends and partners at Elevation Health Partners, and they will be leading you through the content of today's webinar. So at this point, I am going to pass control of the webinar over to Natalie Martin and let her take it from here.
Great, thank you very much, David. Hello, everybody. Happy afternoon. As David mentioned, we're Elevation Health Partners, and today we're going to talk about the ADT IT factor, breaking the case on high utilization with 7 simple use cases. I'm going to test my browser here. Sort of just test that I can manage this. Give me 1 second while I try to advance the slide. There, whoops. Okay. Lauren, was that you advancing the slide? It doesn't appear to be working for me. Okay, just bear with us as we get the navigation going here.
No, you should have keyboard and mouse control. So you should be able to control it either with your mouse or with the arrow keys.
Okay, here we go. I think, all right, the arrow keys are now working, I believe. Okay, thank you, David. Okay, so our learning objectives for today are to learn the importance of sharing timely utilization data between the health plan and the practice, to share lessons learned from a California data sharing pilot of the top 7 ADT use cases to improve CQM performance and generate hundreds of millions of dollars in savings, the benefits of streamlining a notification system for practices when patients visit the ED or hospital, the value of engaging patients with their primary care providers post-discharge from an inpatient or an emergency department visit, and evidence-based methods on how to decrease utilization in the practice setting. Very specifically what a primary care practice can do. Okay, and I am, Okay, I think there's just a delay, so I will wait for that lag. I'm Natalie Martin. I'm the president and CEO of Elevation Health Partners. I founded the organization back in 2006, and my expertise is in designing and implementing tailored, innovative approaches to evidence-based care, value-based payment, data sharing, community-based care models with sector care collaboration, addressing clinical and social linkages, and just general technical assistance to practices. And I'm joined here by my colleague, Rachel Proud. She's Senior Managing Consultant for Elevation Health Partners. Rachel, if you'd like to introduce yourself.
Sure. Good afternoon, everyone. Thank you for the introduction, Natalie. As the slide states, I am assisting Elevation Health Partners with efforts to optimize EHR use and data reporting with our practices that we work with, as well as engaging the patients and families that they serve, and optimizing transitions to community care settings such as acute hospitalization, follow-up, increasing frequency of medication reconciliation, and improving patient medication education and management all care settings. I do a lot of the work with utilization with our practices and the relationship with the health plans, and I have been with the company since October 2016.
All right, thank you, Rachel. So I'll begin our webinar today with a reflection from Samuel Johnson. The chains of habit are too weak to be felt until they are too strong to be broken. So in all of this work, it really does require sort of a change from leadership's perspective, change management within the organization to do things a little bit differently. And so we're always reminded of, sort of the strength of habits and some of the techniques that we can use to create new ones. So today we'll introduce Elevation Health Partners. We won't go over all the slides that I have for you there. You can refer to them in the future if you'd like. But we will go over sort of a background and history of ADT and just ground everybody in what ADT is and what the data feeds are. We'll talk about some early success in San Diego. And then we'll demonstrate the impact of ADT data feeds through a more recent project in Los Angeles regarding those top 7 use cases that I mentioned. And then we'll save some time in the end for questions. So at Elevation Health Partners, we aim to elevate health for all populations through non-generic, tailored solutions for our clients, forward-thinking and never settling for traditional approaches. Our work is really anchored in the goal of achieving health equity for all and the potential that it carries for a healthier democracy and society. As I mentioned, we were founded in 2016 and we're headquartered in San Diego. We are a woman-owned small business consulting firm and a Los Angeles local small business enterprise. Our clients include policy and advocacy groups, philanthropy, grant makers, health systems, as well as county, state, and federal agencies. And our coaching model is centered on working shoulder to shoulder and in the field with practice teams, and we enjoy an unmatched track record in developing and leading large-scale programs to achieve improvements in health outcomes and CQMs. There are just some fun facts for us here on the next slide, but we are pre-qualified for large-scale projects with the LA County CEO's Office in Strategic Planning, Process Improvement, and Performance Measurement, and our faculty for the National Association of Community Health Centers. Regarding practice transformation and interoperability work, as well as preparing practices for value-based reimbursement strategies, we Payment, Learning, and Action Network, or the HPC LAN, which was started when the Federal Transforming Clinical Practice Initiative launched in about 2015. We are a member of All in Dash, or a collaborator. We are also collaborating and a committed partner of the Gravity Project, which seeks to identify a more relevant code base for social determinants of health to document the work that we're doing in the primary care setting as an example, or at least that's our participation. And we are also a member of Hunger Vital Sign National Community of Practice. I'll leave the team expertise there for you to reference in the future. And in terms of our work with ADT and interoperability, Elevation Health fields a team of 16 quality improvement practice transformation coaches to support both 23 Los Angeles-based community health centers and over 50 small practice to achieve, federal practice transformation aims. In 2 years of interventions, our health centers have a demonstrated 8 to 29% improvement from baseline for all 4 clinical quality measures, with 17 of 23 showing a 10% improvement for all CQMs. And the entire cohort of this Los Angeles Practice Transformation Initiative has achieved over $136 million in cost savings and reduced ER hospitalization utilization for patients diagnosed with diabetes and depression. And Elevation Health Partners also supports San Diego Health Connect, the health information exchange, the regional health information exchange here in San Diego, serving our Southern California counties in strategy and capacity building efforts. And we're leading an evaluation project to demonstrate, who benefits when the HIE is able to collaborate with 211 San Diego and its community information exchange for social linkages or social determinants of health. And so we hope that this work will lead to some of the foundational business case for social referrals, closed loop referrals here in our community. So I thought I'd step back for a minute and just talk about what is our concept of interoperability, because it's really critical to this national and statewide conversation that we're all having right now. And so I went to the Institute for Electrical and Electronics Engineering, or IEEE as it's pronounced. They have a standard computer dictionary that defines interoperability as the ability of 2 or more systems or components to exchange information and to use the information that has been exchanged. I think for those of us with a deep history here in interoperability in California, that concept of use is really, a critical distinction. Health information exchange is different from health information operability. Exchange is necessary for interoperability, but it is not sufficient by itself to achieve health information operability. And I would say that, we could debate the philosophies on it, but we're just really drawing the distinction between the technical capability and the responsibility of the organizations that are enabled through those capabilities to use the information. And that's where a lot of the really hard work on the part of participating organizations or linked or connected organizations within a community. And then according to HIMSS, interoperability is the ability of different information systems, devices, or applications to connect in a coordinated manner within and across organizational boundaries to access, exchange, and cooperatively use data amongst stakeholders with the goal of optimizing the health of individuals and populations. Right, so the point here is that, ADT feeds in particular are not a, if you build it, they will come. But as you see from the HIMSS definition, interoperability is not meant to allow access, just to allow access to a system. We're really talking about how we can cooperatively use data with very specific care goals in mind. So for ADT definitions, HL7 ADT data feed stands for admission, discharges, and transfers. It basically means demographics. And that would be your patient's name, maybe location in the hospital, his or her address, phone number, gender, etc. But the HL7 ADT messages keep the patient demographic and visit information synchronized across the ecosystem, right? So when we talk about an organization like San Diego Health Connect, you're talking about a regional capability. In the project that we're going to highlight later on in the presentation, we're going to talk about just sort of a more kind of simple approach for a health plan outreach to some very specific entities, and so that is sort of a much smaller ecosystem, if you will, or we probably wouldn't reference that as the full ecosystem. The ADT function enables providers and care teams to follow up with patients to improve the process of transitioning from inpatient to community-based care settings and to reduce the likelihood of readmission. That's one primary function that we've been involved with consistently here in California. And we find that the ADT data feeds are really helpful and really necessary. And in areas where we have them, they provide tremendous benefit to accountable communities projects, whole person care or whole person wellness as it's known in San Diego, the Health Homes Initiative, and then any other programs targeted at specific utilizations or high utilization or avoidable hospital admissions. So for example, we will talk a lot today about ED and inpatient, but you'll also hear some examples of where it's just important to know when an individual is in a specific care setting. And in that case, ADP is really our linchpin. So the 7 demonstrated use cases for the type of impact that we're going to talk about today are reducing inpatient ED utilization for patients diagnosed with diabetes and depression. And really, you can focus in on any diagnostic codes if you want to narrow the scope of your project or your pilot. To improve 14 and 30-day follow-up rates after hospitalization. To address follow-up after hospitalization for patients with multiple chronic conditions. And that's in another example of a program focused on that is our Health Homes program. To follow up after hospitalizations for high utilizers. This is still an issue in many of our California communities. We found a really specific use case in following up with a mother after newborn delivery. This can be critical for practices that also provide newborn care and are looking to maintain continuity of care with the mother and then also initiate pediatric services for newborns. And to not lose those patients to other organizations as well, so for continuity. Follow-up after hospitalization for patients diagnosed with mental illness, and then readmission predictive modeling. I will mention that arguably there's a payment or incentive side to this. And so the 2 codes that are listed here are reimbursements that are available under Medicare as of right now. As many of you know, we have a rather complicated reimbursement or payment sort of delivery system here in California. And so what's available on the Medicare side is not always available on the Medi-Cal side, and capitation plays a role. But the idea is that there is demonstrated value in these services, and we're seeing an increase and an acknowledgement of the kind of effort that it takes to put something like ADT data to use. And again, just a reminder that hospitals have an incentive to adopt ADT notifications as they don't get reimbursed for avoidable hospital readmissions, and especially for those readmissions within 30 days. So ADT is nothing new. The importance of linking demographics and encounter data, has actually, was part of the sort of original accomplishment of our first health information exchange in 2005 with the Santa Barbara data exchange project. In that particular pilot, the ADT data was sort of connected and developed and not necessarily put to use. But the idea is that this was designed or anticipated to be, some of our lowest hanging fruit for what we could do with health information exchange and to really sort of achieve the real vision for interoperability. However, many of our California communities still aren't there. And as an example, we were doing this for the first time in Los Angeles very recently. So there's still a lot of opportunity in putting just ADT data to use, for the practice or the health plan. So our earlier ADT beginnings are in San Diego include the San Diego Health Connect, which has been supporting ADT-based notifications since the 2010 Beacon funding, which originally funded the development of the HIE. For San Diego Health Connect, the HIE sits on all the integrated EHR networks in the community and has the permissioned capability to snag ADT as soon as it is generated. So this keeps that those capabilities very real time, which you'll see as we talk. The time frame for this data to be utilized to have impact is an important factor. And this ADT in San Diego supports value-added services to the entire HIE network. And some of our more recent examples to serving seniors downtown when one of their members accesses a care setting. And the importance of this example is that it doesn't just have to be hospital and inpatient. There are a lot of applications of this data. And also to assist in whole person care, again in San Diego, that's whole person wellness, but I know we have a broader audience here on the line. But to assist in that recruitment by notifying the program when a candidate is in a care setting. It supports public health reporting, so for electronic labs, syndromic surveillance, immunizations, and then again, as we're going to talk about in more detail, providing alerts of patients for admissions and discharges in acute and ED environments. Project 25 is sort of demonstrates some of our early history, at least from here in San Diego, of extracting the true benefit of simply the ADT feed and the workflow and the organization that can be put around that. So this was a pilot program funded through United Way, the City of San Diego, and the county from 2011 to 2015. And an evaluation conducted by Point Loma Nazarene University highlighted that the 28 participants cost the community $35 million in a year prior to enrollment. And by the conclusion of year 2, costs had decreased by 72% and produced an overall net savings of $3.7 million. So in 2015, Project 25 was expanded to serve high-cost, high-utilizing homeless members referred or funded by the 4 local Medi-Cal managed care plans participating in the whole person wellness pilot. So we have a history of really sort of building on this work and the capability in the San Diego community through the HIE. And then, in addition to Project 25 and the foundation that we have here with HIE, San Diego has a more rich experience in coordinating community-based care through participation as one of 7 counties in the CCI-Cal MediConnect program for dual eligible beneficiaries. And there are many other examples where ADT is really sort of the foundational building block to achieve the goals and start some of the care coordination workflow for these special programs. So now we'll turn to a California data sharing pilot of the top 7 use cases that we put earlier. And we're going to draw a link to just simply using ADT feeds to improve CQM performance and to generate hundreds of millions of dollars of savings in avoidable utilization, particularly of the ED. So this particular pilot, the health plan wanted to identify, the health plan worked in advance to identify the high need, high cost members who've not seen their PCP in the last 15 months and haven't received a follow-up visit with their PCP after hospital utilization. So that includes the inpatient stays and ED visits. And so the first effort was really to build that list. And I'll just stop, but the purpose of sharing this level of detail in the presentation is to give you a sense of how you might structure a particular within your community, or conversations as a practice that you can have with a health plan in terms of closing the loop, or if you represent some of these other special special focused programs. This will give you an overview of just some very simple steps that we took to launch this pilot and to achieve our results. So the project sought to achieve an overall 20% reduction in inpatient ED utilization for patients with diabetes and depression from the baseline year, which was 2015. And we had 4 years to accomplish another $60 million in cost savings. But we also wanted to re-engage members in their care and improve health outcomes by bringing patients into the practices for primary care and care management, to assist practices in increasing their incentive and payments under the P4P program, and assist the transformation project in meeting goals around utilization management, cost savings, and practice transformation. So we started with just an alpha test with one federally qualified health center to get just some very early feedback, and then expanded into a beta test with just 5 FQHCs. And we wanted this very short-term effort, sort of following like, quality improvement model, to see, to do these really short iterations of change. So we didn't want to take on a big elaborate project that would take months to develop. We wanted to do something that was a little bit lean and mean so that we could, really sort of, innovate much more rapidly. The health plan secured the ADT notifications in near or real time from 42 hospital sites prior to the pilot launch. And that was really critical in terms of bringing the practices to the table. And then we waited until the health plan was able to deliver weekly ED data or ADT feeds to the practices. When we originally started conversations for the pilot, the health plan was not quite there yet. At one point we were at 30 days, and then we determined through our pre-engagement activity that it was going to be really helpful to do it weekly. While real-time and daily feeds sound great, we also learned from the practices that they, that wasn't really realistic or actionable for them, and so weekly was still, a rather aggressive timeline to be following up and instituting this new workflow. And then we used the LAPTN practice transformation coaches. Those are provided exclusively by Elevation Health Partners to support the clinics or the practices in developing the workflow documentation and support them on this journey. So the health plan provided data on active members assigned to the practice with the recent emergency room or hospital admission use. The list of the participating hospitals was also shared with the practices. And the data that they were receiving through this pilot was timelier than the claims and encounter data that they were currently receiving, through any other mechanisms that they may have had. We also found it necessary to develop a simple workbook data dictionary so that everybody knew what the definition of the data was, how it originated, so that they could use it properly. And then we produced a data dashboard. From the coaching support perspective, the Elevation Health Partners practice transformation coaches provided dedicated support to the participating practices. So we held a very official, in-person kickoff meeting, including a training presentation regarding both the pilot and the value of ADT data. And then we were there to answer questions and address concerns. And then we also had weekly one-on-one check-ins and feedback sessions with the practices and the health plan staff to review what was working, what was not working, and what are the challenges. And the health plan was really at the table to address issues as they came up, when that was possible. And that was also another kind of critical factor. So we also used an outreach worksheet with a drop-down selection for each row to be filled by the practice as they work through the list. And so we identified what statuses would be relevant to the project, understanding that these feeds would come in and one feed may not be related to another feed. So it was going to be important for us to know who we had reached out to and when, and really lacking any other tool, like a broader sort of regional care coordination tool, we were able to just capture this information in Excel. And then from here, so that's sort of the overall program structure. At the end of this next section, we're going to share with you what the actual results were for the project. But we wanted to take you through also the practice view of participating in this project. And for that, Rachel is the coach assigned to Harbor Community, and she is going to share with you how Harbor approached their participation in the pilot.
Yes, thank you, Natalie. So yes, I am the QI coach assigned to Harbor Community Clinic, and they were one of the beta pilot sites that participated. It was great working with them, and we developed this workflow that you can see here on the slide. They had one dedicated staff member that participated in the pilots, along with myself, and then occasionally their main case manager at the site provided input as requested. So in terms of the workflow, at the very beginning, this is where you would receive the data from the health plan. And of course, the data was encrypted. The patient navigator worked on going through the file, making sure everything was filtered properly. And what it means by the pilot filter is that, how Natalie kind of mentioned a couple slides back, is that these were patients that were identified by the health plan that had not had a PCP visit in the last 15 months, and they had at least one type of utilization visit, whether an ED or inpatient admission, and they're assigned to the clinic, but they're not coming in. So in the very beginning of the pilot, actually, that filter was not applied. It was something where the clinic staff had to go through that themselves, and usually the QI coach, whoever was assigned to the clinic, would work on that with them. So we ended up having the health plan kind of do a macro on the spreadsheet, so it automatically filtered. So when the staff opened up the spreadsheet, it was ready to go. So it saved them some time, streamlined it a bit, and it made sure that the correct patients were being targeted for outreach. So the staff would go through each one, and then something that they had to notice right away was that some of these patients, of course, based on the filtering of who's being sent to the clinic, these patients have not come in most of the time for at least 15 months, or they have not established care at all. So there is no record on file. So the staff cannot, use a record to reference for contact information or see if there's any details on what's going on with the patient. So they had to rely on the sources from the health plan to contact them. So they had those steps in place for determining what to do if the patient was already established at the clinic or not. Maybe they just hadn't come in a very long time. And then they would work on either using the contact information in the chart or just the contact information in the spreadsheet if there was no record for the patient in their EHR. And then the steps of when to leave a message, when it's appropriate to speak to family or a friend if they answer, and just relaying the message to the patient to call them back. And all these outreach notes were documented, not only in the spreadsheet from the health plan, but in the patient's chart if that was available as well, just to make sure that everything was documented. And then the spreadsheet from the health plan, we used that during the weekly check-ins, where we went over the work that was done in the previous week, discussed any issues when there was contact established with the patient, and then in terms of accurate or inaccurate contact information, that was always discussed, as that was a very popular issue that we identified throughout the pilot. So those were the steps that we took. And then, of course, I feel like this is somewhat standard across the different clinics that we work with. But in terms of contact and not being able to establish contact with them, they would try 3 attempts, via phone call. And if not, we would send a letter to the patient, either from the contact information in the chart or the spreadsheet from the health plan if that's all they had. And then one other step the patient navigator actually realized during the pilot was that if the patient does have a chart, and it doesn't seem that the contact information is correct from this health plan or the direct contact information for the patient in their chart, the emergency contact section of the chart actually sometimes provided additional numbers we were not aware of. And say next slide. Okay. So I know that was kind of just all written down on that previous slide. It's sometimes, it's easy to just jot it down one by one like that. But this is for those that are visual. You can kind of see the basic steps of what we did during that 45-day pilot with Harbor. So, we show the date in April of when we received the original file. The patient navigator started working on going through all the data, making sure that, if there's any issues, they identified them so that we could provide that on our check-in call. He worked on doing the outreach to the patients and documenting his work. One piece that we had added was that in the very beginning of the pilot, the actual hospital name was not included in the spreadsheet and each row was a patient on that spreadsheet, and they didn't have that detail. So that was something the health plan was able to add for us. So it just made it a little bit easier to track where they were at. And then, receiving the second file with the next week, you can see there was only a few new patients on that file. And I wanted to mention Harbor is a smaller clinic in terms of how many patients they serve in the San Pedro area. And so, some of the files seem to have a little bit more patients, some had a lot less. And that's actually a trend we've seen post-pilot as well. And then you see the third file was received with 13 patients, going through that, documenting the outreach. We'd have the check-in with LA Care. And then the fourth file only had 1 new patient, going through the steps of the workflow. Then, reaching out, sending those no contact letters to the patients we were not able to establish contact with. And then in the beginning of June, wrapped up the pilot, worked on summarizing the findings. And then we did end up having kind of a wrap up in-person meeting with the health plan to go over everything. Okay. And then in terms of outreach results, this is kind of a list of, in terms of the patients that contact was made or was not made with. You can see the exact steps that were taken. This is related to the drop-down list Natalie mentioned previously on that spreadsheet, where it was easy to keep track of what happened in terms of the outreach. So many patients had a letter sent to them since no contact information was correct, or even if if they left a message, they still did not receive contact, and that's that 14 patient column. So maybe a phone number did work, but there was no established contact after those calls were made. Luckily, we didn't have any patients that when contact was made, they were interested. Patients were either established or not established and took the time, to try to have an appointment scheduled and get those follow-ups taken care of. And then, you can see the amount of patients that came in: 8 that were completed with an actual appointment, 9 were made with that 1 that no-showed though. And then there were 2 patients that were showing not assigned. That was a discrepancy we discovered very early on in the pilot in the first spreadsheet, since I had mentioned that, the criteria to be included was the last 15 months. And when the first data sheet was run by the health plan, some of the patients on those lists were actually, they were active back during, in the last 15 months, maybe last year, but they, for whatever reason, have a different health plan now or have switched providers. And that was something that was not filtered for in the beginning. So we made sure that that criteria was edited by the health plan so that when the clinic received their weekly lists, those patients that were on them were truly still assigned to that health plan and assigned to the clinic. And then there were 6 patients that had no contact. Okay, so again, a lot of words on the slides, but I'm going to try to summarize it for you. Overall, and actually not only at Harbor, but across the other pilot sites, the majority of the utilization was in the ED. Very few patients were on the list that were admitted into the hospital. So that was very insightful, not only to, I think, the clinic, but the health plan found that very interesting as well. Just realizing that these patients on these lists, not only are they listing the hospital, but they're also listing their reason for visit. And, it was kind of interesting to take a look at that from a clinical perspective at the clinic and see, maybe, some of these patients that have not established care, they most likely could be avoiding these ED visits if they're actually coming into the clinic, and, the provider would be addressing what's going on with them. And then, unfortunately, I was only able to establish contact with a handful of the patients throughout the pilot. Wrong phone numbers, inaccurate numbers did play a role. I think this is something that even outside of the pilot clinics, with the practice transformation project we've been working on for the last 3 to 4 years, it's very, very difficult to always have accurate contact information for these patients. And so this pilot kind of solidified that again. But that's something that the health plan's aware of. We're trying to work on, other resources in terms of pulling contact information, including pharmacies, and, just solidifying and confirming with the hospitals that, when they're seeing the patients and in terms of care management, discharge planning, that they truly do have the correct phone number for them. And then one particular thing that Harbor did request was they wanted to see, in terms of that original file of patients in the beginning of the pilot, what their utilization costs were. And there was only 2 of them that they could really look at that time, just due to claims, the 3-month lag, the minimum of that. But they did determine there were a few patients that, obviously were high utilizers. They were incurring, between $35,000 to $54,000 in their utilization costs, and that was just 2 patients alone. And then at the bottom of the slide, as you can see, one of the patients ended up showing twice. That at first we thought was just an error when we had those weekly check-ins and we reviewed that at this particular health plan, they do have plan partners, and that the patient actually had switched plan partners. So that's why it just happened to be a very odd circumstance where they showed twice, because it was with 2 different entities. But that was something that was identified and resolved. And then the last point was that these clinics that are participating in the pilots, they were interested in these ADT files because they felt, this is different based on clinic. As we've learned working on this past year, some clinics have some sort of establishment with the hospital or the health plan, different health plans or IPAs, medical groups that are sending them faxes of patients that have been in the ER hospital, but it's usually not very timely. There's portals that the IPAs have. And so it might not necessarily always be updated, and these ADT files have proven to a lot of these clinics that have participated that they are more timely than a portal update or waiting for that discharge summary to be faxed over from the hospital. It's kind of hit or miss with that depending on the relationship or how close the hospital is to the clinic. So these ADT files, you know, are regular, they're timely, they come every week on the same day, and that proved in this particular case with this patient that the clinic was not notified of the discharge until 8 days after the patient left. And that at that time when we were looking at it, the patient wasn't actually even in the portal either. The clinic only knew because of the discharge summary. So in this case, you know, we were not able to get the patient back for a follow-up visit post-discharge within 7 days. And so that was one of the use cases that getting this weekly, we could try to get that appointment scheduled, you know, within 7 days or 14-day follow-up. Those two measures we did definitely track. In terms of the summary, it's been proven that specifically for Harbor, this ADT data has been very helpful, and to this day, we actually still receive it on a weekly basis, and that, you know, patient outreach, having someone dedicated to that work is very effective and important for establishing the contact and getting those patients in for follow-up care, and especially for the patients that are constantly visiting the ED or hospital and are not coming into the clinic, and obviously we feel that that would probably decrease if they were coming into the clinic and establishing care with the provider.
Okay. Thank you very much, Rachel. This is Natalie. You know, I'll say too that, you know, I do remember that for Harbor that, you know, the fourth data file that came through, you know, had one, you know, new patient on it. And the reason for that, the data service was actually back in April. And that was an interesting example of how, you know, the sort of the claims or the delay in claims adjudication can impact, you know, a project like this. As Rachel also mentioned, we had practices with quite a variety of resources and capabilities. So as a small practice or a smaller organization, you know, Harbor was able to really manage this, you know, through the Excel spreadsheet. You can imagine at scale, you know, that could get really complicated with kind of like a fresh list coming in each time or each, you know, every week. And then the, you know, needing to sort of reconcile like what you've already done with the patient, if you've already outreached, you know, if they were present on the list before. So, you know, this isn't necessarily like the ideal process, but it was a really great project to understand, you know, what the detailed issues are and to reveal those, and to also inform, you know, how could, you know, what are the factors to look at to bring this project to scale? What does it look like if it's enabled by, you know, the lanes, IE? And then additionally, you know, what additional tools do we need, you know, to track some of this, you know, activity among the practices? And so overall for the full pilot, the early results were an overall 8% reduction in ED all-cause admissions. And then all pilot clinics combined, and some promising results from individual clinics that participated in the pilot that had sort of a greater degree of success. And then a 3% reduction in inpatient. As Rachel mentioned, you know, the real finding here was that there was a high level of ED utilization. And so, you know, the real gains were in bringing those patients back into primary care. The pilot has resulted in a full expansion. So the health plan now facilitates weekly delivery of timely ED and IP notifications from 44 hospitals to 23 FQHCs and 9 DHS facilities. And then the solution that was used in this particular project was eConnect, and that ADT data is shared. So some of the limitations were that it was shared with, you know, just on a weekly basis. And again, some of the agencies or practices have the capability to use more timely data. If we were to be able to pair that with other data factors, it could be even more useful. Like especially if we were to, you know, focus on, you know, asthma or cardiology and that type of a thing. And then that the results are close approximations, and a 4-month claims delay is also, you know, taken into consideration. And I think, I didn't put it on here, but through this work, I think I'll pull it up here. The overall for the project to date, with the interventions and the CQMs and the ED, the progress that's been made in the avoidable ED utilization, the health plan has saved over 136 million in cost savings attributed to EHR hospitalization utilization for patients diagnosed with just diabetes and depression. So this project demonstrates that we are just scratching the surface on the type of impact that we can have when we're able to leverage this data among hospitals and primary care practices. And with that, we have about 15 minutes left, so we'd like to open it up to questions.
All right, thank you, Natalie. And for the folks on the phone who are listening, if you do want to ask questions, you should see a question box on the right side of your screen. If you can type in questions, so far none, but we are, anytime now you guys want to jump in. I will, now that I start off with this, one of the things that always comes up on these calls is folks ask if the slides are going to be available. So I know from the CalHIPSO side, I'll just let everyone know after the end of the webinar, we will always post the recording of the webinar, and we put it on our YouTube channel. You can also find it linked to the CalHIPSO website at calhipso.org. So be looking for that if you want to go back and hear this again, or if you have colleagues who weren't able to make the call today, you can point them there. Other than that, it looks like now that Rachel, looks like you must have covered everything because we are not getting any questions coming in.
All right, no problem.
So I will put one quick plug. I hope everyone will save the date for Thursday, May 7th, 2020 for the 2020 CalHIPSO conference, which we have titled the Interoperability Agenda, very appropriate with the topic of today's webinar. Be looking for more information at www.calhipso.org/events. For any follow-up questions that you may have later, feel free to email us at info@calhipso.org. Oh, and now I say this, and it looks like one question has come up just under the wire. It looks like now that someone has asked, were ADT alerts going directly into EHR?
Rachel, do you want to take that?
Sure. Yeah, the alerts were not going into the EHR. It was the file was being sent through an encrypted email. So that was something that when we established care with each pilot site, we had to come up with an email, usually more generic than a specific staff member, just in case there was turnover, where that file will be sent every week, and that person will be responsible for accessing it and opening it on the computer.
Okay, thank you. That is the only question, but seeing as I tried to wrap before and then somebody jumped in, I think I'll wait one more minute. In the question box, questions going once, questions going twice. Sold. Okay, thank you. So thank you to our partners at Elevation Health Partners, Natalie and Rachel. Thank you for sharing your expertise with us today. Thank you for the folks who attended. Be watching CalHIPSO newsletters and announcements for next month's webinars. We don't have it planned yet, but we do this at the end of every month, and hope to see you next month. Thank you.
Thanks, everyone. Thank you, David.